Jay, and this is where I introduce you to amazing people like you who are doing great things in the world that I think you should know about. Well, today is the second Wednesday of the month, which means it's time for our plant-based cardiologist, Dr. Baxter Montgomery. And today he's going to be talking about the critical role of cardiac testing. Please welcome him all the way from Houston, Dr. Baxter Montgomery. Well, people love this topic because everybody's always asking if they should there's some scan, I guess, that people are interested in that kind of
Yes.
tells them where they are from a cardiac standpoint and should they get it. So we're going to find that out today.
Yeah, so we get a lot of questions, of course, in our office and patients who come and, we'll order tests and say, well, can I see the blockage or will it show this or that? And so I decided to put together a brief talk. It's really an overview. Each one of these tests can have a talk of its own, but I thought I'd just give an overview on cardiac testing. So let me share my slides here and we'll get into it. So in essence, cardiac testing, what do they mean? And as I said, we're going to do an overview of cardiac testing and we'll talk about, how you decide which test does what. But for the most part, you should know that there's no one test that's perfect. That's one. Two, testing is something that it's like detective work. The first thing you do is you talk to the patient and you try to find as many clues. So we're going to take it from a global perspective in terms of how you evaluate somebody from a cardiovascular standpoint, and then how do you use the test in the context of that. But before I get into that, we often get questions on our YouTube channel, also on Chef AJ's channel. There are a lot of questions in terms of how to get started, the nutritional diet. So I'll give some information that we share with our clients in terms of ways of getting started. And here's a few quick bullet points. In our book, Food Prescription for Better Health, it gives an outline in terms of how to start in terms of nutritional detox. It talks about our concept in terms of how to detox the food classification system. So that's a very good start. We also have an online community. You have access to me directly. You can ask questions once a month. Plus, there are other guests that we bring on, experts like Chef AJ, who's been on there. And then, of course, people can have an assessment call. Oftentimes, individuals come on our channel and they'll have certain illnesses and they need help with. Just give us a call or you can make an appointment. And of course, we have our docuseries, Heart and Soul of a Champion. Season 1 deals with athletes, where we took some athletes beyond their prime who had lots of chronic illnesses and they came through our program. So you get an inside look at how people go through the program from a three-dimensional standpoint. So these are some areas where I think there'll be helpful resources if you want more information. So let's get to the topic at hand. Our basic overview is cardiac testing, but really it deals with patient evaluation. Cardiac testing should be in the context of evaluating somebody with an illness. In this case, we're talking about a cardiac illness or potential cardiac illness, but it's any patient with any illness. So the first thing you want to know in general is what's happening with the patient. 85 to 95% of diagnosis can be made from just talking to the patient. So hopefully your doctor is the type of person to ask the right questions and they listen to you. I like listening to patient stories, and there may be things that may seem irrelevant, something about their vacation last year, or something about their children and how their children behave. But all that can be valuable information and give you insight in terms of who that person is, how they behave, how they think. The next thing we try to do is find out what's happening in and around the cells. That may include blood tests, functioning of the heart, and then the functioning of the vascular system is a key thing. We would also like to look at, get information rather about related organs. So if we're looking at the cardiovascular system, we don't stop at just the cardiovascular system, but we try to get information about what's happening with other organs. For instance, the kidney, the liver, if there's some dysfunction there, that can give us information about the heart. For example, oftentimes I'm seeing very sick patients with weak hearts. If I see the kidney function improving, that's telling me that the heart may be improving because perfusion to the kidneys improving. So we'll go over some of these things to share with you. first and foremost, once we've taken a detailed history of our patients, we'll get a set of blood tests. And my approach is simply this. I'll talk to the patient based on the information I get. I'll come up with a differential diagnosis. A differential diagnosis is just a fancy way of saying a list of possible causes of the patient's problem. And so I'm going through that thought process in my mind. So, okay, I think number one is possibly this, or that. And so I'll start to get tests. Some of the tests we start with are blood tests. Now, these biological markers look at a lot of different things. We look at metabolic condition of the body, the lipids and the lipoproteins, insulin level, glucose levels. That looks at the metabolic process, how the liver's working, how the muscles are working. There are certain markers that look at the condition of the cardiac muscle. Then we look at an ultrasensitive troponin. There may be also a basic natriuretic peptide. These molecules, if they're increased, that may show that there's some stress, some either ischemic stress or mechanical stress on the heart muscle cells. Then there can be markers of vascular structure. So asymmetric and symmetric diethylarginine are elevated when the endothelial cells are not optimally functioning optimally. And so these are some markers that we can look at to give us some idea of what's happening at the vascular levels. And then there are other markers that we look at that shows us that there may be some amount of increased inflammation. C-reactive protein looks at systemic inflammation. You can get a high sensitive C-reactive protein, which looks more at cardiac inflammation. Myeloperoxidase gives you a little insight in terms of inflammation in the blood vessel. So the blood markers can be very helpful in giving you insight in terms of what's happening at the biochemical state or at the cellular level. Next thing, we will look at the electrical testing of the heart. The simple electrical testing, the EKG, or also ECG, cardiogram in Germany is spelled with K, so in the US we spell it with C, so that's the difference there. But it detects and measures electrical signals of the heart, and it gives us information not only in the function of the heart, but also the structure of the heart. On the EKG, sometimes I can tell whether the heart muscle may be thickened. I can look and see maybe one of the atria may be enlarged or dysfunctioning. So it can give us an idea in terms of what's the structure of the heart. We can look and see, okay, someone may have had a heart attack on a certain part of the heart muscle. So we can get that information from a 12-lead EKG. Cardiac monitoring gives us real-time monitoring of the heart rhythm. And it also gives some structural information, but as individuals may have certain symptoms such as palpitations or sensation of racing of the heart or skip beats, we can determine the nature of those abnormalities or the nature of those symptoms, I should say, by looking at an ongoing monitor, the monitor that someone may wear on a regular basis. Here's a look of a 12-lead EKG. If you isolate the focus where my arrow is here, you see a little bump, and then there's a spike and a hump, another bump, spike, hump, bump, spike, hump. So these things represent a cardiac cycle. The little bump represents electrical signal passing through the atria. The spike represents electrical signal passing through the ventricle. This is bigger because the muscle in the ventricles are larger, so it sends out a larger electrical signal than in the atrium. And this hump represents recovery, electrical recovery. We call it repolarization. But the heart muscle cells are polarized. So there's electrical charge on the inside the cells, positive on the outside. And when electrical current passes through, that polarization flips over. And once that current's passed through, it has to flip back over and become repolarized in the native way. And so this represents sort of a global repolarization of the heart muscle cells. So here you have, again, the diagram, the P wave is just the terminology. That's when the electrical signal passes through the atrium. The R wave is to the ventricle. And this little pink line here is where it goes through this filter called the AV node. And this is where the signal slows down. That's why you don't see any electrical up or down, because this is sort of flat, because sort of electrical silence when it goes to this AV node. And this behaves like a breaker system. This prevents lots of electrical if you go into atrial fibrillation, it prevents lots of electrical signals from the atrium from going to the ventricles. So it keeps, so if your atrium is going like at 300 beats a minute, it suppresses some of those signals. So your ventricle don't go 300 beats a minute and you die. And so then the repolarization is again when you have electrical recovery in the ventricle. So repolarization in the atrium occurs during this phase, so that's why you don't see it. And so this part repolarizes also, but it's covered up by the electrical signal in the ventricle. Oh, by the way, here's a normal beat. The closer these spikes are together, the faster. The farther they are apart, the slower. And of course, the irregularity here, you can see if you have like extra beats, etc. Cardiac monitoring, you wear these little devices here. Monitors have gotten, the technology has gotten much better. So about maybe 3 times the size of a quarter. This can fit under any shirt or blouse very easily. And our patients can wear these up to about a month. You also have these implantable devices where you put under the skin. We call them implantable loop recorders. These have battery life somewhere around 3 to 4 years. They fit right underneath there, right over the heart, and we can get continuous beat-to-beat analysis for a matter of 3 to 4 years. And this is good for individuals who have arrhythmias that you want to monitor for a long period of time and adjust medications or make a diagnosis in some cases. Now, what about the physiology of the heart? First and foremost, we do stress testing. Stress testing gives you lots of information. Basically, a 12-lead EKG, you have someone exercise either on a bicycle or a treadmill. Sometimes we do just like a step test with a 12-lead, and it gives you heart rate and blood pressure measurements. You can also see what the EKG does with exercise, if the heart rate picks up appropriately, etc. If the heart rate slows down after rest is over, those are all important data points to evaluate the person's cardiovascular physiology. And also it gives you information about their fitness and functional status. Hemodynamic testing, blood pressure and heart rate is a very good hemodynamic test. It's non-invasive. There's also devices that can measure thoracic fluid impedance in the chest. It's also non-invasive, so we can get lots of detailed information such as cardiac output and resistance and circulation here. And then, of course, there's an invasive procedure called right heart catheterization, where you get access to a vein, either in the arm or the leg or the shoulder, and you can flow the catheter into the right side of the heart and directly measure pressures inside the heart. And then there's also vascular response testing that gives you information on the physiology of the circulation. The endopat test looks at endothelial function. Cardiac sinus massage looks at autonomic nervous system and cardiovascular system interaction. And so those tests can give you information about physiology. And of course, tilt table testing is also good for central nervous system and cardiovascular system interaction. And we use this to evaluate people with fainting, and same thing with cardiac sinus massage. So let's take a look at what it looks like. Someone on a treadmill. So you have a technician here. They're monitoring things. They take a blood pressure 2 minutes into each 3-minute phase. Every 3 minutes, it speeds up and the incline goes up on the typical Bruce protocol. There are other protocols that are more or less aggressive than the Bruce protocol. You also have hemodynamic testing. Here's your famous blood pressure cuff, which, hopefully many of you have at home, and you can check your heart rate and blood pressure at rest and also after you've done things. The thoracic impedance test is a special device. We put electrodes on the chest here, also on either side of the neck, and it measures the changes in impedance based on fluid shifts. So you got blood volume moving up, you got, of course, the chest wall moving, fluid moving in and out of the lungs. So it's looking at all of those changes and giving you calculations based on circulation. This is what's called a catheter. We call it a Swan-Ganz catheter or right heart catheter. You have you can flush fluid through the tip here and draw blood samples through the tip. This little syringe here injects air through a balloon that's right about here. So once you get this catheter in the heart, you inflate the balloon, it sticks out around there. And that balloon, because it's a balloon, of course, the actual blood would then float it through the heart to where it needs to go most of the time. Sometimes you have to do a little manipulation and put a wire in there and manipulate it the way you want. This can go in through the groin or through the arm or through the neck. And it floats up to the pulmonary artery right about here. And we get pressures here that can do calculations on cardiac output and vascular resistance. So we get good information. This is often done in the in the cath lab. The advanced heart surgeons do this a lot with their heart failure patients. And of course, it's done in the ICU from time to time to monitor patients who are very, very sick. Vascular stress response, carotid sinus massage, patients lying here. Of course, you check for bruits, and then you find the carotid pulse. You have the patient with a 12-lead EKG connected, and when you say go, you massage one side, and sometimes you can see here, you see one-to-one from the P waves, and all of a sudden you see this pause here. And so that's resulting from a carotid sinus massage. You call that a hypersensitivity carotid sinus hypersensitivity syndrome, where if you massage the carotid node, the carotid sinus, you'll cause a pause. And this oftentimes the people who, when they turn their head left or right, or up or down, they get dizzy. And so you get that sign on the history. You say, oh, this is carotid sinus, hypersensitivity. I'm going to do this test. So just a little bit of snippet in terms of how the history then leads you to this test. You don't do this test on everyone who passes out. So if you come and say, well, I've been passing out. So why are you passing out? Well, the room starts spinning around and I lose control and I pass out. Okay, well, that may be vertigo. It could be something else. Or, when I lift my head up or down to the left, I get a little woozy and sometimes I pass out. Well, if it's related to turning your neck around, that could be carotid sinus hypersensitivity. So then I would do this test. So that's how the history can lead to a certain test. And of course, vascular response testing. This is an endopat test. You have the blood pressure cuff here, and you have probes on the fingers. These probes are measuring capillary flow or arterial flow through the fingers. And so you get flow measurements, and then at a certain part of the test, you occlude one. You occlude flow to this one. This is the control. And then after a certain period of time, you release this, and you look at a response. So here, you see one finger was the control. So when you have the blood pressure, say this is the right arm of that patient, it's the left, and this is what you measure, the finger probe. This represents the flow through the artery. So while the right arm pressure is occluded, there's no flow to the side, but this side is seeing flow. And then when you release the cuff pressure, you should see a hyperactive, we call it hyperactive hyperemia. So in other words, the flow shouldn't come back to normal or less than normal. It should go above normal. And this is a normal response. If it had come back to say the same as this, then that'd been abnormal. Cardiovascular physiology, echocardiogram. Typically we do a transthoracic echo. Just to orient you, the echo probe is here on the chest. The right ventricle sits anterior or in the front. Left ventricle sits toward the back. The left atrium sits toward the back. Here's the aorta. So right ventricle, left ventricle, you see the papillary muscles here, the mitral valve, and of course the left atrium is back here, and the aortic valve is the aortic outflow tract there of the aorta. And so here is another view. This is the probe just rotated in a different way. And we call it the apical view, the left ventricle here, the left atrium's here, right ventricle's here, right atrium's here. This is the pericardium, is pointing out a little bit of fluid around the heart. Some people have pericarditis or pericardial fluid buildup. You can see it right here. Sometimes you want to get a closer look at the heart. When you're looking at the heart from the front, you have the ribs, you have to, angle the probe through. But if you want to get a closer look at the heart, you may put the probe behind the throat, through the esophagus. And so you do we call it a transesophageal echo, or TEE. And we do this frequently in patients who need cardioversion, or we doing some evaluation for valve repair or replacement. So you get a real close look at that mitral valve there with the probe from the back. And so that transesophageal echo gives you lots of information. And we often look into the left atrial appendage to try to find, to see if there's any thrombus. Here's the position of the patient on their side, and the probe is gently inserted through the esophagus. Now, perfusion tests, oftentimes people think about coronary angiograms, but oftentimes we'll look at a perfusion study. It's an indirect way of looking at blood flow in the heart. So this looks at, this perfusion study looks at, uses technetium 99, and you see the different cuts. So this is a donut cut, and this is a sagittal, and then kind of horizontal here. So you got the horizontal, the vertical rather. And so in this, you see the anterior, you got the inferior wall, you got the septum, the lateral, and you see the bottom here looks really thin, and it starts to come back here. So that's what we would call some ischemia, because this is doing stress and this is doing rest. So if you have less uptake during the stress is at the top. So this is an easy one to look at. There's less uptake here compared to here, the bottom. So that's called ischemia because you have decreased uptake during stress compared to the rest phase. You see a little bit here in the apex here. Stress is defective, it comes back during rest. This is a PET scan, a different type of radionuclide tracer, but you have a similar type image. You see here during stress, and during rest, it comes back. There's probably disease that's also fixed because this rest is not stone cold normal, as you can tell in some of these images. But you do see improvement. So that will tell you that, you know, in this this segment of the heart, you have an area where there's viability. So if you go and do a coronary angiogram, then you'll have some idea as to whether, you know, you should revascularize that area, be it bypass or coronary angiogram, or you can do it just with a diet. But this is a great beginning and after. Another image of a PET, much more drastic changes here. Anterior wall comes back. This wall comes back, the septum and lateral wall. And this wall does not come back very much. It's a scar. So this image showed you scar in the anterior wall. So that's some examples of ischemia and scar. And here's a coronary angiogram. This is, you see the catheter comes up here. It's about a 6 French JR4, and you inject in the left main, and then you see, you know, blood coming around the circumflex. Here's the LAD. Here's the right coronary artery. And so you can see the dark part is where the contrast goes to. So that's where the artery is open. If you saw part of this being pinched off, that'd be an area of stenosis. These arteries look pretty good. The right circumflex giving off the obtuse marginal. And so those arteries look pretty good there. This is a CT coronary angiogram and also calcium score. So this test is a little bit less invasive than the previous one I showed you. The previous one typically will place a catheter in the arm or the groin and advance the catheter up to the heart itself and inject contrast directly into the heart. With the CT coronary angiogram, there's an IV, so it's a vein stuck, not an artery. A vein is stuck in the arm, and contrasters run through that vein. And due to special programming of the CT scan, they can catch the contrast as it goes through the coronary arteries, as you see here. And they can get a pretty good look at the coronary arteries. You see these splotches here are calcium deposits. And so you can get a scoring system. There's a calcium scoring system that we use to determine what the calcium score is. And we can also look at perfusion. And one of my old studies, I used to do electrophysiology studies. So there's a way to look at the electrical part of the heart from inside the heart. So we're all familiar with having an EKG done, where you put the electrodes on the chest. Well, an electrophysiology study is an EKG from inside the heart. And electrophysiologists like myself would spend lots of time in labs where we place catheters in the heart and we can measure electrical signals to get much more detailed information about the electrical signal, his bundle of his, the atrium, the ventricle, and we can determine, sometimes you have to do this type of test to determine the nature of someone's conduction system, whether or not they're at risk for passing out due to cardiac arrest, or whether or not they're at risk for passing out due to a conduction block. So this gives good information, also helps us diagnose certain arrhythmias such as SVT, and we can also place catheters in to ablate certain pathways. So we can then do curative therapy. So if some people have SVT, you may have an accessory pathway somewhere in this area, so we can put a catheter there and burn that accessory pathway and cure that tachycardia. And here's an image of the setup of an EP room. Pretty fancy stuff there. These guys are doing a pulmonary vein ablation or AFib ablation, where they look at the pulmonary veins and he's manipulating the catheter there, and he'll isolate these pulmonary veins as a way of preventing further episodes of atrial fibrillation. So in summary, I've gone through giving you quite an overview. It's not exhaustive, but again, I want to reemphasize that no test is perfect. Multiple tests can work together. In fact, I like to put multiple data points together. Making a diagnosis, in my opinion, is like detective work. Patients come in, they have certain complaints. Patients with similar type disease states or health conditions may have very different manifestations. Someone may come in just with fatigue, and somebody may come in with shortness of breath. Someone else may have chest discomfort, and they may all have the same, condition, but different manifestations. So you want to look at the history and look at different tests. And some people, this test may be normal, but that test may be abnormal, and other people vice versa. So you put it all together, and it's like detective work in terms of saying, okay, based on all the data, this is what I think is happening. And but testing should have a purpose. So if your doctor is recommending that you have an echo or stress test, or especially the invasive test, he said, well, you need a heart cath. We say, okay, well, what's the purpose? What are we going to do? And the question I always ask myself when I recommend a test, so like my PA comes and says, I think we should do this test. A common set of questions said, well, what are we going to do if the test is normal? And what are we going to do different if it's abnormal? And so how is the test going to change our treatment? So that's always a good question to ask than many others, but you always want to do that because the testing should have a purpose. And of course, make sure you understand the risk, benefits, and overall objectives of tests, because that's really important. If you're the patient or your loved one's a patient, you want to make sure that all these things are understood, so you and your doctors are going in with a solid game plan and a solid purpose. Anyway, thanks for your attention, and we can take some questions.
Yay. Thank you, Dr. Montgomery. That was really interesting. I remember my dad had one of those procedures a long time ago, and the thing broke off in him. You know what I mean? Where you go in the groin, and it was a
Yeah.
big deal. Like it was a big deal, like crash cart and everything. Like, you know what I'm talking about? The glass thing broke inside of him.
Oh yeah. If a catheter or something breaks inside it, that is a big deal.
I just remember that. I was little, but I still remember that, it was like,
Wow.
yeah,
Yeah.
yeah. Anyway, very cool. Well, if you guys have questions, please put them in the chat, but we did have a couple that were submitted in advance, and this is
Sure.
basically on topic because you are a cardiologist, and this is from Esther, and she said, Dr. Montgomery, what would be my best option? Open heart surgery or stents? I'm 66. I have genetic heart disease, 3 clogged arteries, 70 to 80% LPA, 20 LP little a 2021, APOB 146, vegan 14 years, whole food plant-based 3 years.
Yeah, that's a great question. Bypass versus stent. My attitude is always go least invasive. So start least invasive to greatest invasive. So then it's a great question because it gets to what a lot of what we're talking about, because then It's about the question, that question I posed about testing could be also posed about treatment. So, for example, what are your objectives? Because if your objectives are, okay, I have multivessel disease, I'm completely asymptomatic, exercising, I'm doing fine, you may want to hold off on bypass for sure, because that's the most invasive. And then you say, okay, what about stenting? Well, then you have to say, okay, what am I trying to achieve? So if you're asymptomatic and someone does a coronary angiogram and you have, coronary artery disease, and they say, well, look, you need, stents, and you say, okay, I'm running marathons, I'm feeling great, I'm enjoying my life, I'm exercising, etc., have no symptoms, eating a healthy diet. You may step back and say, okay, what else is there short of stenting? Oftentimes I see patients come in on a whole food plant-based diet. But even a whole food plant-based diet can be optimized. There are nutritional detox approaches and the like. If you get a book, it talks about that. So that's the approach I take. You have to, the answer to that question is going to be determined based on your objectives. Neither stenting or bypass is going to give you prolonged survival, statistically speaking, nor will they prevent future cardiac events. Now, let's say someone's in the throes of a heart attack and have an acute coronary syndrome. Yes, go in and get a stent done. Or they have an acute coronary syndrome and they have disease that's not amenable to stents, medically stabilized, and maybe consider bypass surgery, especially if there's severe disease that can't be treated with stenting. So typically those procedures are going to be done more in an urgent or emergent situation as opposed to in an elective situation. But sometimes individuals can benefit from one or more of these procedures electively, depending on the circumstances.
That's interesting. Well, remember what was that saying? Prevent, not stent.
That's right. That's the preference. That's the
Yeah.
preference.
Well, if somebody chose to get the stent, could they still then, if they wanted later, get the open heart surgery?
Oh, sure. Those things happen interchangeably on a regular basis. Now, part of the issue is the timing. So if you get, a lot of stents in one vessel, it makes it hard for the surgeon to bypass or tie into it. If you get stents done and then shortly after have to have bypass, oftentimes you have to be on the antiplatelet drugs for at least a year. So sometimes, there's some um, um, maneuvering that you have to do with the medications and things. But yes, people get bypass after stents.
Do these procedures, they don't really get to the root of the problem, do they? And if their people are unwilling to change their diet or lifestyle, do they even work?
Well, the data suggests that they don't work. Now, in a situation where it's an acute intervention, emergent, they work. For example, I remember I was in the cath lab implanting a defibrillator, and our cath lab at our hospital has, we have like 6 different rooms, and the procedure rooms all next to each other. So I was just finishing a defibrillator implant, came out, and the room next to me, they were rushing a patient in there. And so I just stuck my head in the control room and went in, and they were doing CPR, chest compressions on the patient. And it turned out it was an anesthesiologist who was, in the hospital, just walked out the doctor's lounge, had cardiac arrest right there in the hospital. And so they immediately coded him, did chest compressions, and got him to the cath lab. And so my colleague had, got access to the groin, ran the catheter up, and when they saw the heart on the floor, the heart was at standstill. And so they injected contrast, saw the LED was occluded, got a wire across the thrombus, opened it up, and of course the heart started back. And so that's a situation, that's a true save, with the stent. Now, that's not every case, but I give you that extreme example to say, yeah, these procedures can be very effective in certain situations. And even people who have started a detox diet, they may have lesions that are so unstable that they can have an acute event before you get them stabilized. And so sometimes they may have to go and have a stent in one vessel and then you come back and detox them or nourish them for the rest of the vessels. So you have different scenarios that you have to deal with. And so we like to think of it as an integrative approach where we don't totally discount the potential need for an intervention, but we think that the interventions are needed much less than what they're frequently recommended.
Thank you. Hey, let me just read this nice comment that I just read from one of the live viewers on Facebook. Norma says, I enjoy Dr. Montgomery's lecture so much. Even my cardiologist knows who he is. That's great.
That's
Okay.
great. Thank you very much for the kind words.
All right. This is from Tina. I have had an irregular heartbeat that races a couple of times a day. It's been happening for about a year in spite of a whole food plant-based diet, an ideal body weight. I don't consume any chocolate or caffeine. I had a 24-hour Holter monitor and it came back normal. Is there anything I should be concerned about, or should I have further testing for that?
Yeah, great question. Further testing probably include an extended monitor. The monitor I showed, the little patch monitor, you wear those up to 2 to 3 weeks at a time. And you can wear those in the shower and they give you extra stickies. But you need more than 24-hour monitoring. You need maybe 3 week, 4 week monitoring. It depends on the frequency of the irregular heartbeat. So if you have an irregular heartbeat, and that's one thing, again, the history. So I go to the history and talk to someone. I have an irregular heartbeat. Well, what does it feel like? How often do you have it? Oh, every now and then. What's every now and then? Once or twice a month, or every other month. If it's every week or every day, then maybe a 24-hour monitor will work. If it's once or twice a week, then I'm going to put an extended monitor on, have them wear it for 3 to 4 weeks, or I should say at least 2 to 4 weeks, and then we should likely pick it up. So the history will give me a clue as to the frequency of the arrhythmia, and then that will tell me which type of monitor to use. So here is a situation you may need more monitoring. The other thing we do talk to patients about from the standpoint of arrhythmias, we do recommend micronutrient testing. It gives you a little bit of insight in terms of micronutrients that you may be deficient in. So you maybe do target micronutrient supplementation, magnesium, and or various other supplements that can help out with arrhythmias.
Perfect. Thank you. This is a question from Linda, thank you, Linda, for sending it in advance, but she's also watching live, I see, because she posted it in the chat. She said that what could cause someone's lips to turn blue? My sister is experiencing this issue. It comes and goes. The first time it happened, she visited the ER and had a battery of tests and told all the results were normal and was sent on her way. Days later, it happened again. So she consulted her GP, still no diagnosis or answer. She's 59. She snores loudly, but has yet to schedule a sleep study. She's about 50 pounds overweight, but very active. She has a rope vein in the thigh of one leg for which she has sought treatment for a blood clot. So is this a circulation problem? Of course, she does not follow a whole food plant-based way of eating or lifestyle. And any information on what to do when one's lips turn blue on and off?
Yeah, typically, I mean, when you see blue, well, this is the lips, but similar to the lips and extremities. But when the lips are blue, it's more of a central, we think of it as sort of a central cyanosis. When extremities turn blue, it's more isolated to the circulation. So when she's having a change of blue lips and things like that, oftentimes you want to look for shunting. Sometimes people have cardiovascular shunting that can cause sort of a central hypoxia, sort of a centralized, we call it central cyanosis, meaning that you're not getting oxygen to the certain parts of your body. So central areas like the lips will turn blue, as opposed to just extremities turning blue when it's isolated to circulation. So she may want to have more cardiac testing, maybe an echocardiogram, make sure there's no shunting around the heart. And then, of course, you still can have isolated vascular problems associated with the lip. And so you want to look at that as a problem as well, as a potential problem as well.
Thank you. This is a question from Marshall. And he says, that he has an irregular heartbeat, and they really haven't said whether it was AFib or AFlutter. It happens every couple of weeks. And he either gets really tired from it or feels a lot of pounding in his chest. He's 64 years old, follows a very healthy SOS-free diet. For something like this, do you recommend medication or ablation or both? And you don't do ablations, right? You're not a
I'm an electrophysiologist. Yeah, I've done ablations for over 20 years. I don't do them now because I'm going more into integrative medicine, but I've done AFib ablations, flutter ablations, avian VT ablations, and defibrillator implants. So that was my areas. That is my area of expertise, although I have a colleague that does the procedures for me now. But from the standpoint of now, he says an irregular heartbeat. That's not a specific enough diagnosis. So I don't have enough information to say you need an ablation. If it's irregular because you're having PACs or PVCs, it may be due to electrolyte abnormalities. If you're having certain arrhythmias that are due to like a reentrant tachycardia or something like that, then those are things that we would tend to go in and ablate.
I see. When the people go on the medication for that, is it the blood thinners that they're going on?
It depends. So if something like atrial fibrillation, they're commonly prescribed an anticoagulant or blood thinner, as you said. But atrial arrhythmias like flutters and like an atrial tachycardias, if you will, they're often anticoagulated as well. In addition to giving medication that may suppress the arrhythmia or medication that may control the heart rate when you're in the arrhythmia.
Are you able to do a consultation with somebody that's not living in Texas virtually, or do they have to come into Texas to see you about this problem?
Great question. We are designing virtual consultations. They're non-medical, but they're virtual consultations are coming, I'd say coming soon. The first ones will be released in July. We'll start the marketing in June, either July or August. And it'll be where I look at all your records and go through everything and look at your medications and give you my opinion as to what I think is going on. So the answer is yes, it's coming either July or August.
That
And
is
we'll be
fantastic.
announcing that. Yeah,
And then from what I understand, then the patient could live in anywhere.
that's correct. Yeah.
Oh boy, I want to be the first one to sign up. Not for me. I mean, but for a family member that has a
Good.
cardiac problem. That would be give me the first appointment, will you? I mean, oh, that would be amazing. And then I could tell everybody how great it was. Thank you. I'm so glad I asked that.
No problem.
So Jennifer says, are veins in the legs that are large and blue something that should be checked? Is it a concern at all regarding one's heart?
Great question. So veins in the legs that are large and blue. Again, it all depends on the cause. So, people have varicose veins for lots of reasons. Venous insufficiency can contribute to varicose veins and other things. So it's not only the enlarged veins, but other things that may go along it. So if there's swelling, if there's discoloration of the extremity, things like that, that may be a sign that your flow through those veins are not very good. Someone who's very muscular and they work out a lot, they may have large veins in the leg that are just, physiologically large because they got good return and healthy veins. So you don't want to go on just the size of the veins, but what goes along with it. Is there pain, is there swelling, discoloration, extremity, etc.? Those are things you want to think about. And if you have those things associated with, then you want to do some investigation, do a venous ultrasound, Doppler study to see if there's reflux or other things, make sure there's no blood clotting, etc.
Thank you. Teresa, who's watching live on Facebook, says, what test is the best to determine what condition my blood vessels are in? As far as I know, I'm healthy, but I just want to know if the blood vessels in my heart are in good condition.
So great question. So and again, the arterial blood vessels are the key ones you want to look at. We look at several tests. So from a blood test standpoint, the ADMA or SDMA, the asymmetric or symmetric dimethylarginine tests are good to determine endothelial function. We also do the endopat test, which looks at the one that I showed you with the blood cuff on one arm, looks at the hyperemia. And so those blood tests and that physiologic response test, those are a good combination of tests to look at blood vessel function.
Thank you. Jennifer says, how can a family member who takes injections to keep the cholesterol normal but wants to stop the shots, how can one do that safely? She's whole food plant-based 70% of the time. I wasn't aware that there was a shot for cholesterol. Do you know what that is?
Yeah, these you have most common ones are the PCSK inhibitors, and those are little shots you get. There are also some other injections that are fairly new, but yeah, those are typically used for people who either uh, don't tolerate statins at all, or their cholesterol are not adequately controlled. It maximally those statins, so they'll add those to a statin drug. And so those are used. Now, berberine is a natural PCSK9 inhibitor, but they mentioned it's 70% plant-based. So one thing you do is give the other 30% plant-based, so that can help. And then you go there. So your 100% plant-based diet gives you the best chance to get your cholesterol normalized and make sure, of course, it's not, processed foods with oils and so on.
Yep, great. C says, is there any value in paying attention to gym equipment such as a treadmill heart rate or gym fat percentage scales?
Great question. It just depends on the quality of the machines. I mean, I would imagine most of those heart rate monitor machines are pretty good. That technology is, I think, fairly old. The percent fat machines, that's, I think, a pretty solid technology in terms of a mature technology. So I imagine the technology there is such that most gyms can have adequate equipment. What I would say is this: if you go to one gym and you use the equipment all the time, and let's say your fat percentage starts at N and then it goes down to one half N, well, at least you have a before and after, and it's the same equipment. So whether that percentage is precisely right in terms of your body percentage is one thing, but let's say it starts off at 30% and goes down to 15%, then you say, well, okay, I've reduced it in half. So whether those percentage numbers are exact is one thing, but at least you know what the change is and know that you're moving in the right direction. So that's one good thing about it. But I would imagine most of the equipment's going to be decent. But that's going to be the same as submerging in water and the skin pinchers as well.
Oh, what do you like the bioimpedance analysis for body fat percentage?
It's good. I haven't looked at the data comparing bioimpedance with the calipers. And the because the so-called gold standard is the water submersion test, which I remember doing when I was a fellow. And of course, you have the skin calipers is supposed to be next to that in terms of they do the pinch test to measure your body fat. So I don't know how the impedance compared to those gold standards, to be honest.
I think it's hard to find the dunk test these days, you know?
Yeah, yeah. You probably have to go to where I had mine done was at the hospital in the cardiac rehab facility.
What's your body fat percentage, if you don't mind sharing?
I haven't had it measured in a long time. I mean, it's like way back then. In college, it was 3%, and it had gone up to like 12% when I was in my training. So I was out of shape. So I don't know what it is now. Maybe I need to go and get dunked and
You
figure
look great. You don't need to do that. I was just funning you. Okay,
out.
so Monica says, is a myocardial perfusion test safe with radioactive dye? There will be a treadmill involved. They did a resting test first. Is there a better way to check your heart for any issues?
Well, the perfusion test it's I mean, safe is one of those relative terms. The answer is yes in general. You'll be exposed to some amount of radiation with most of the tests, the invasive tests, because whether it's radiation from the tracer or radiation from the imaging part, it's going to require some radiation. So these tests are reasonably well tolerated and reasonably safe. Obviously, you don't want to be doing them, every other month or something like that, but it's a relatively safe test.
Nice. Okay. Connie wants to know, how long does it take for, it says restenosis. Maybe she means just stenosis to occur. 88-year-old male had MI, stents, bypass, pacemaker, and valve replacement. It's been 11 years, but it still eats poorly, cheese, white bread, eggs, and hot dogs. Oh, restenosis. I get it. Restenosis.
Yeah, restenosis is something that can occur at any rate. So it just depends. I mean, I've seen people with restenosis. I've seen people with acute restenosis. I mean, right immediately after the procedure, you have thrombosis, et cetera. But typically what we do is patient who received intervention with a stent, they receive antiplatelet, aggressive antiplatelet therapy for at least dual antiplatelet therapy for 12 months after the procedure. And then after that, they can go with just aspirin. Now, it depends. If someone has lots of inflammation, oxidative stress, they have restenosis even sooner. Or stenosis at a vessel that's remote from the vessel that's stented. So it all depends on what's happening with that person's physiology and biochemistry.
Fantastic. Thank you. Marty wants to know, or sorry, Marley, do you see patients just for preventative care due to a family history of cardiovascular disease?
Yes.
Nice. That was a quick one. Good, easy question. And Monica says, is there a way you can detox radiation faster?
I don't know the answer to that because I haven't looked at any studies that compare one way or the other. So to say what's fast or what's not, you certainly want to consume lots of super greens. You want algae and sea vegetables, lots of antioxidants because radiation brings about oxidative stress. So you want to consume sea vegetables and greens. Healthy sea vegetables and greens are good ways of doing that.
Perfect. Deborah says, I've had an HDL of in the 42 to 45 range for the last 15 years. My total cholesterol was 167. I'm working on getting my total levels down. I'm not sure I can get my HDL up to the 50-60 range that's been recommended by doctors. Any recommendations? My healthcare system is advised that my numbers are within the normal range. We get that a lot on this show because my understanding from Dr. Clapper is that your HDL, it's like your garbage truck. And when you don't have garbage, you don't need garbage trucks. And so that low HDL isn't necessarily a big risk. What do you think?
Yeah, I use a police analogy, same difference. The thing is that my global answer to that question is don't focus on numbers because any one given number is not going to be the end all be all. The issue is simply this. Cholesterol does a lot of different things, and a lot we know about and a lot we don't know about. HDL molecules serve many purposes that we know about that we don't know about. And so we don't want to just isolate these things into one area. And that's why using a drug to get a lab value to a certain number is not something I subscribe to strictly. That can be helpful in some circumstances, but your LDL at 160, okay, is it at 160 because your body's preparing nerves? There could be some nerve damage, a high nerve turnover. There could be lots of things going on inside your system, inflammatory conditions, breakdown, repair. Cholesterol, maybe you're not getting adequate, sunlight exposure and you need more vitamin D and you may be upregulating your LDL cholesterol or cholesterol in general for that. There any one of a number of things that could be going on why your cholesterol numbers are that number, which is not super elevated, but just because you want an LDL cholesterol of 120, I wouldn't, fuss over the number per se. Look at general aspects of your health and make sure you're addressing your health. I've seen lots of people with LDL cholesterol of, 85 or 75 who, have, health issues of different types, even cardiovascular disease. So you really want to look at the global aspects of your health and look at what you're doing.
Perfect. Thank you. Let's pop over to Instagram. We're multi-streaming to 4 places: YouTube, Facebook, Twitter, and Instagram. So I have to jump screens to find other questions. But here is Winky Love, cute name on Instagram. What are your thoughts on L-arginine for endothelial dysfunction? It's helping me with my chest pain.
Yeah, L-arginine is great. We use it for our patients. If you get a good supplement, quality supplement, it's good. It enhances nitric oxide production, which improves endothelial health and well-being.
Nice. Okay, that's good to know. Yes, they said they were a heart attack survivor, but now has endothelial dysfunction. And Patty on Instagram says, I have AFib. Will I eventually need a pacemaker?
Not necessarily. Everyone with AFib doesn't need a pacemaker. I hear that question often with AFib, and I'm not sure if doctors are telling people that or not.
She says she has
Paroxysmal atrial
yeah,
fibrillation.
and she's on metoprolol and flecaine.
Flecainide?
Yeah, yeah. The doctor,
Trouble on flecainide?
I think that's what she wrote. The doctor didn't think she needed a blood thinner.
Okay, so she probably has lone atrial fibrillation. So lone atrial fibrillation is when you, and just a little quick blurb on atrial fibrillation, and maybe I'll do a talk on that one day, but atrial fibrillation, the concerns with atrial fibrillation is that you get, if you develop persistent atrial fibrillation, you can, go into heart failure. You have low cardiac output syndrome. It also puts you at risk for stroke through the embolic stroke. And of course, the tachycardia itself can be, make you symptomatic, short of breath, angina. So atrial fibrillation deals with three main issues: stroke prevention, heart failure prevention, and also heart rate control for symptoms and functionality. Now, typically people want to put on the metoprolol, helps with the heart rate, and flecainide helps keep you out of AFib. Now, some people do the pill in the pocket where they take the flecainide only when they feel AFib. I don't do a lot of pill in the pocket. If I have someone on an antiarrhythmic, I'll have them on it or not on it. And so, but from that situation, if your doctor don't think you need an anticoagulant, then you don't have a high enough CHA2DS2-VASc score, put you at risk. CHA2DS2-VASc score, the name's not important, but basically it's a scoring system used based on all the comorbidities you have. So you get 1 point for being a diabetic, 2 points for having had a stroke. If you're a certain age, you have a point. You have coronary disease, you have a point. Diabetes give you a point. Heart failure gives you a point. So the more of those things you have, if your score is like greater than 2 or greater, then they recommend an anticoagulant. If it's 1, then it's a gray zone. If it's 0, then you're not getting an anticoagulant. But that's the issue there.
And that's called the CHAD, CHAD.
Yeah, CHAD, yeah. Chad, Vasc, VAS, CHAD dash VASC with a little tube at the C subscript 2. That's the most updated score. They have
Interesting.
what's called the Has-Bled score, which is what's your risk of bleeding. So you got CHA2DS2-VASc versus Has-Bled. Has-Bled due to AIDS, history of bleeding before, et cetera, et cetera. So if I'm going to put someone on an anticoagulant, they're an older person, had a brain bleed, a GI bleed, then the Has-Bled score is going to be high. They've had a history of diabetes and high blood pressure. CHA2DS2-VASc score is high. So which score is higher? Because there's a risk benefit to each.
Seems like the hardest thing about being a doctor is remembering all the words and pronouncing them, you know?
Yeah, I look them up frequently.
Oh, that's something. You have the best laugh. Kelly says, could having RA increase my total cholesterol and triglycerides?
That's a great question. So rheumatoid arthritis is an inflammatory condition. This is a systemic inflammatory condition. Now, we give labels to things. So although yours is labeled rheumatoid arthritis, keep in mind that your inflammatory process can affect any part of the body, including the liver. So people with rheumatoid arthritis can have liver inflammation. So if the liver is affected somehow, then liver metabolism can be affected, and therefore, cholesterol metabolism can be affected directly, indirectly. So that's one thing. Plus, of course, treatment of rheumatoid arthritis or inflammatory conditions oftentimes, consists of medications that may predispose you to increased cholesterol. So the general answer is possibly it could. It just depends on the mechanism. So if you have some liver involvement in the setting of your inflammatory condition, then cholesterol metabolism could be affected.
Thank you. Okay, this is from Mike, and Mike says, it's about LDL and HDL. They're normal now after being elevated for years, thanks to a whole food plant-based diet and getting back to a healthy, normal BMI and blood pressure. But I'm still experiencing triglycerides. I'm guessing high triglycerides. What can cause this? Should I be concerned, or will this normalize eventually?
Well, it depends on your trajectory. So you've had high cholesterol before, and I guess you've changed your diet and the triglycerides are still high. It all depends. You want to look at check your hemoglobin A1C, make sure there's no insulin resistance, make sure there's no underlying inflammatory process going on. Make sure you're not consuming a lot of processed foods in general. Uh, those things can cause the triglycerides to go up.
Okay, and then he's saying his A1C is good. Okay, well, cool. Da, 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 da. What if your heart rate is on the lower side, 55 to 60? I'm vegan. Is that the cause?
Well, I wouldn't say vegan itself is a cause, although in our studies, we show when we put patients on a defined plant-based diet, heart rate significantly decreased over 4 weeks. So, having said that, a healthy diet can contribute to healthy hemodynamics, and healthy hemodynamics include a lower heart rate. So, I wouldn't say it's just because of the vegan diet per se, but a defined plant-based diet was shown to decrease heart rate. Now, the other physiological factors, if you exercise on a regular basis, some people have a genetic increased parasympathetic tone, which tends to give them lower heart rate. So a number of factors that are at play.
Thanks. Susan says, if you have low blood pressure and it's from a diet like ours, SOFA free, and you undergo a trauma or operation and your blood pressure dips dangerously, how can you fix it? Add salt?
Well, it depends. Yeah, you may add salt or other things, and we have people have low blood pressure for lots of reasons, and oftentimes patients have neurogenic hypotension or neurocardiogenic hypotension. So they walk around, they're fatigued, the pressure's low. We may add sea salt to the diet. You also want to consider what's going on with the adrenal gland. Look at the serum sodium levels. See if the serum sodium levels constant in the 130s, then you may be sodium depleted. There's a lot pushed on these low salt diets. And even some of my colleagues say no salt. But I think the absolutism is not ideal because, there are people that, even in my practice, my practice is skewed toward people with cardiovascular disease and hypertension. And we see a significant number of people who have to add salt to their diet. So it's something you want to be mindful of. And if your pressure is too low and you have low sodium, have your adrenal glands evaluated. You may not be balancing your mineralocorticoids adequately. Of course, check your thyroid gland, other hormone things. So thyroid, even though the thyroid hormones may be quote unquote normal, we look at patients' TSH levels. The TSH levels are like 2 or above, or 1.5 or above. We think that some of them may be iodine deficient, so that can affect the adrenal thyroid axis. So there are a lot of variables that are involved in this, and so. But sometimes people do have to add salt to their diet.
Yep. Interesting. Jimmy says, my leg vein ultrasound showed venous reflux. Any suggestion other than wearing 20 to 30 millimeter of mercury compression socks as prescribed? Cardio says it's not heart related.
Yeah, well, I mean, it's a venous insufficiency, so it's a vascular issue. So, indirectly it affects the heart. So, there are they do vein ablation, which is an invasive procedure. We also prescribe these pneumatic devices for our patients. So, especially if the stockings don't work, the insurance companies cover it. It's I can't think of the name of the device, but it's a pneumatic device that massages the legs, mechanical rollers in these boots they fit on your leg, and you wear them for like 45 minutes a day while at home watching a Netflix movie or whatever. And I actually tried one on when they started working with our patients, and it feels very good. So that actually works very well for reflex. So those devices are good.
Or they can watch Heart of a Champion, your documentary, while they're wearing
Heart and
it.
Soul of the Champion while they're wearing. That's exactly right.
That's even better than Netflix. That was a good series, and they can still watch that. Judy says, I had open heart surgery to replace my aortic valve. My diaphragm is now 1 to 2 inches higher on one side. Can anything be done to correct it? I still have trouble breathing, and it's been 9 months.
Yeah, they may have damaged the phrenic nerve. Um, see a pulmonologist, I think there are some um, things that you can do to help the phrenic nerve recover. But I would see a surgeon, of course, and see a pulmonologist because it sounds like you've had the phrenic nerve damaged, and so it may take longer to recover. There may be some special things that they have to do physiologically to help you breathe better.
Yeah. Latif says, what routine tests are recommended for a 79-year-old male that has had a triple bypass surgery performed 2 years ago? What extra care should he take?
Well, certainly you want to be on a healthy diet. We promote a plant-based diet here, exercise. You want to follow your inflammatory markers and the like. So I would see a cardiologist at least once or twice a year. My patient had bypass surgery. We see our patients much more frequently, once or twice a year. But for a patient of mine that's recently had bypass surgery and is serious about making lifestyle changes, we will definitely put them on a plant-based diet. We'll have them do detoxes on a regular basis. And so we'll monitor them very closely, get echocardiograms, stress tests on a regular basis.
Nice. I think there's just one more question. I know I got to let you go. You're a busy working doctor and we appreciate all your time. Anne says my triglycerides are 50, but my LDL is 100. All other markers are good. I've been trying to get that LDL down. How harmful is an LDL of 100 if I have a low triglyceride level?
Yeah, I don't think it's very harmful. I mean, if you're not having to take medications to keep it at 100, I don't think 100 is a problem. Again, I really wouldn't focus on the number.
Nice. Well, people don't die of the numbers, right? Yeah.
The numbers are what the numbers are. And the thing is that I mean, it's important to look at the numbers and use the numbers, but they're tools. And, oftentimes, our bodies have gone through lots of stress and trauma in the past. And once we start to take corrective action, and if we're taking the right corrective action, our body's going to start to heal itself. That doesn't mean that the numbers always go back to what the biologically normal numbers should be. Oftentimes they do, but they don't always, and you have to take that into consideration. You don't ignore them, but you don't just focus on a given number. Look at other factors. We look at lipoproteins, inflammatory markers, other things, your fitness level, your physiology. That's why we use tests collectively, not just in isolation.
Fantastic. Well, thank you so much. This was very informative, Dr. Montgomery.
Well, thank you. The pleasure's all mine, and I look forward to seeing you next month.
Right. And maybe as soon as you get that system in place where people can have their virtual conference consults, please tell me, and I can add it to the show notes of every show you've done, even past ones.
Awesome. I look forward to it.
And if you could talk about that thing you said you do at your center with for people with cancer to optimize their health, that sounds like a very fascinating topic that really hasn't been talked about a lot on Chef AJ Live.
We'll do it next month.
All right. Thanks so much, Dr. Montgomery. And thanks all of you for watching another episode of Chef AJ Live. Please come back tomorrow at 11 a.m. Pacific time for Vegan Doc Talk with Dr. Scott Harrington. He's going to teach you how to soothe the burn and overcome your reflux with diet and lifestyle. Thanks so much for watching. If you like what you see, maybe subscribe and even consider giving me a thumbs up.